Recording in progress.
I'll give it another minute, but can you guys just tell me if you can see the PowerPoint?
Yeah, we can.
All right, thanks. We'll give it another minute, I guess, unless you think there's maybe going to be a really small group this morning.
I think people are just slowly signing on.
Okay, we'll give it one more minute and then I'll probably just start because there's a decent amount of stuff to talk about. All right, so that probably seems like enough people to at least get started. And so people can filter in, but we'll go ahead. And so I was hoping when I first knew I was going to give this talk that we were going to be back in person, but obviously COVID had other problems. And so we're still other plans. So we're still Zooming. And I think you all probably know this by now from having given your own talks over Zoom, that it's like 100% impossible to tell whether or not people are following what you're saying or are still alive even. And so I don't think there's any way around that, but I will try to keep the chat open, and I would be very happy if you wanted to interrupt me and ask questions or tell me to repeat something or ask me to slow down or whatever. You can shout stuff out too, but it seems like that's harder for people to do. So I will try to keep a peripheral eye on the chat at least. And so what we're going to talk about is some cardiology diagrams. And I called it From Boards to Bedside because I think you all have probably some idea that there's a chance that there may be a cardiology diagram that shows up on boards at some point, particularly general boards, but probably other types of boards too. And so for that reason, that's maybe some incentive to be familiar with them. But realistically, the reason that these diagrams show up over and over again in various different places is that they are actually really valuable, helpful diagrams, and they actually do have a lot of clinical relevance. And we think about elements of these diagrams every day when we do things in cardiology. And so my effort is to try to sort of draw some connections between the things that we study for boards and things that we think about clinically. So The way that we'll do that is first we'll review a few different diagrams, and then we'll talk about two different clinical scenarios, congestive heart failure and pulmonary hypertension, and try to tie the two together. And so for each clinical scenario, heart failure and pulmonary hypertension, we'll just quickly discuss the conceptual relevance of each diagram, and then talk about the fact that, like, we think of these diagrams as helping you conceptually understand something, but the diagrams all contain specific elements that we could measure in any given animal. And we often don't do this, but we think about it all the time. And so we may not always verbalize the way that we're thinking about those connections when we talk about a clinical case. But there are a lot of things that we actually are imagining in our brain that we could physically go and measure on any given animal. So we'll talk a little bit about that. And then lastly, there are things that we do actually measure on a regular basis, oftentimes on echo, because that's the non-invasive thing that we have to do to animals. That is a way of trying to approximate some of the things that we can't always measure directly. And so we'll talk about those things and how those relate to some of the diagrams. So the three diagrams I was going to talk about are the Wiggers diagram, the Frank-Starling curve, or the Starling family of curves, and the Forrester classification scheme, which people may also call the wet-dry diagram. I just read a book by Forrester that was really good, so now I feel like I should call it by its real name, so we'll call it the Forrester classification. And so we'll go through each one of those, and I know you are all somewhat familiar with these diagrams, but we'll just do a little bit of review so we're all on the same page. And so for each one, I tried to, at the beginning, put just like a little bit in words of what I think of as a general summary of the diagram for the people whose minds like words better than pictures. That's not me, but I still think there are some people out there that like it better. So for me, the Wiggers diagram is generally a representation of pressures inside various regions of the cardiovascular system, and it's showing those pressures over time. And it specifically shows the timing of what's happening in related to what's going on the EKG. And it also will show you the heart sounds and the ventricular volume changes that are happening throughout the cycle. And so that may help some of you, but for me, just the words isn't that helpful. So here's your classic picture of a Wiggers diagram. And I think this is like just, it's a great diagram. It entails a huge amount of information all in one little spot. But I also think it's an interesting diagram because I think it's a very polarizing diagram. I think some people learn about this diagram and see it and they think it's just really elegant and beautiful and they love it. And then other people see this diagram and they think it's just the worst. And so I think there are definitely different ends of the spectrum for how much people enjoy trying to think about the Wiggers diagram. So just in case there are some of you out there that are on the I hate the Wiggers diagram end of the spectrum, then I'll talk through it in a little bit more detail. So this is sort of the classic entire Wiggers diagram just taken from Wikipedia, where at the top we have pressures in various different parts of the cardiovascular system. We have the changes in the ventricular volume, we have the EKG, and then we have the heart sounds. And then we have it divided up into big chunks where you have systole and diastole, and little chunks where it has all these different names. And it tells you where valves open and close. And so it gives you all sorts of information. And so I think a lot of you might try to memorize some of this stuff for boards. But in reality, if you understand a few key points about how the heart works, then you don't actually really have to memorize anything. So if in the heat of the moment in boards, you forget the things you've memorized, sometimes it helps to sort of understand how it's working. So one reason that I think people don't like it is that it's a lot of information on one page. And so if we sort of deconstruct the Wiggers diagram and we just take one heart cycle or one systolic cycle of the top part with the different pressures in the different chambers, the thing to remember is that these are just pressure tracings. So these are just the recordings that you would get if you put catheters in various different places. And so the red one, the top one of the top ones, is just almost very similar to what you would get with an art line. So if you put your animal under anesthesia and someone puts an art line in, you guys are very accustomed to seeing the classic systolic diastolic oscillation of an arterial waveform. And the central aortic pressure may be not exactly the same as the peripheral arterial pressure, but they're close enough to each other that you can think of them as generally in the ballpark of the same thing. And you're all very familiar with the fact that a normal animal has a blood pressure that's usually around something like 120 over 80. And so then you'd have 120 up here at the top and 80 down here at the bottom. And it may also be good to know how to calculate the mean arterial pressure. And so then if you knew the numbers in diastole and systole, then sometimes people would say, like, just think about the concept that you spend more time in diastole than in systole. And so your mean pressure is going to be a little bit closer to the diastolic pressure than the systolic pressure. And so the way of figuring it out is usually to take the diastolic pressure and then add 1/3 of the difference between the two. So then your mean arterial pressure ends up somewhere down here. And so that's not exactly something that you always label on the Wiggers diagram, but maybe something that's good to be familiar with. So that arterial pressure tracing that you're used to seeing is just one part of the Wiggers diagram. And then if you had a catheter that was in the aorta and you kept on shoving it into the animal farther and it went backwards across the aortic valve into the left ventricle, then you would get a pressure that looks like this. So then this is the next part of the Wiggers diagram that has the bigger deflection between systole and diastole. And so it's kind of similar to the arterial pressure tracing because it's got like a high point and a low point, but there's a much, much bigger difference between systole and diastole when you have the catheter in a ventricle versus in artery. And so this is when we talk about the Wiggers diagram, we often default to thinking of the left heart, but the right ventricle's pressure tracing would look very similar, just lower pressures than the left heart. And so it's good to like have your brain be familiar with the way a ventricular pressure tracing would look versus an arterial pressure tracing. And so we know that the heart generates all this pressure in systole and then it relaxes in diastole and it gets almost down near zero in diastole. Whereas if you're out in an artery, once diastole happens, the aortic valve and the pulmonic valve close and the arteries have their elastic recoil. And so it maintains a much higher diastolic pressure out in the arteries compared to the diastolic pressure in the ventricles. So you should probably be able to see a pressure tracing like this and know that that really big up and down is classic of the ventricular pressure tracing. And then when you see something that looks like an art line, that's going to be the aortic pressure tracing. And then we don't really do this, but if you kept pushing the catheter farther in and it went backwards across the mitral valve up into the left atrium, then you would get an atrial pressure waveform. And the atrial pressure waveform has its own little bumps with an A and a C and a V wave that happen at different parts of the cardiac cycle. And it's at much, much lower pressure. So the atrial pressure tracing is way down here at the lowest part of the ventricular pressure tracing all the time. And so when we look at the Wiggers diagram, the top part of it with all those different lines going all over the place is really just these three pressure tracings superimposed on each other. So as if you had a catheter in the aorta, in the left ventricle, and in the left atrium at the same time, and you just watched what was happening to the pressures at the same time in each different chamber. And so that's half the battle of understanding what's happening with the Wiggers diagram. But we also know that the job of the cardiovascular system is not just to live your life hanging out in the aorta, going up and down, or hanging out in the ventricle, going up and down, or hanging out in the left atrium. The job of the cardiovascular system is to move things from one place to the next. And that's where I think some people maybe think the Wiggers diagram gets a little bit confusing, because that's one of the things that it's showing you is how and when things move from one place to the next within the cardiovascular system. And so there's, to me, two fairly simple concepts that help you figure that out. And so you could just memorize what each of these little sections is called, but there's two kind of simple concepts that if you can remember them, you can just sort of deduce which thing is happening in which section. And so the first one that I know you're all familiar with and you've all heard lots of times is that blood always goes from higher pressure to lower pressure. That's like an unbreakable rule that's always going to be the case. And like you're sort of familiar with that. It's the same idea as the fact that water goes from a high spot to a low spot. So like if I show you this still picture of a waterfall, nobody would wonder if the water is going from down here to up here. You just know by laws of nature that water is going from up here to down here. And so that's the same thing with the cardiovascular system. It's always going to go from higher pressure to lower pressure. And the other thing that you know sort of intuitively without thinking about it is that it doesn't take much difference in elevation to get water to go from one place to another. And so you know this intuitively because you've probably taken a shower or a bath at some point, and you know that your bathtub has just a drain down here. And when you run the water all just goes down the drain with no problem unless there's something wrong with your floor or your bathtub. And so the normal bathtub has the end of it being just a tiny little bit higher than where the drain is. And so the water just flows freely down the drain. So you don't have to have a bathtub where the back of the bathtub is 5 feet up in the air and the drain is way down here. You just have to have it be a tiny, tiny little bit higher than where the drain is. So those are things that you sort of just take for granted in life. But when it comes to the cardiovascular system, the heart evolved to be very, very efficient. So under normal circumstances, it's never going to waste any energy. It's always going to do just the bare minimum amount of work to get blood to go where it needs to go, which means that you're not going to have giant pressure changes when you have blood going from one place to another. And so the other thing that for me conceptually helps to understand when blood is going from one place to another, and the fact that you don't need large pressure changes to do it, is the way that train tracks work. And so if you had a train track that started down in Southern California and was meandering across the country, and you had another one that was up in Oregon and meandering across the country, and you wanted to get your train from the Southern California train track up to the Oregon train track, you can't just like hurl the train from Southern California up to Oregon. That's not really going to happen. That would take a huge amount of energy. But if the two train tracks meander around and then somewhere in the middle of the country, they run right next to each other like this, then it's really super easy to put the train on either track going forward once they diverge again. And so for me, the Wiggers diagram does the same thing. So blood only goes from one place to another when the train tracks are running kind of near each other. And so if we look and we see when does that happen? So it happens up here, and this is the same point. This is just another cycle repeated. So we have up here a high point where the two train tracks run near each other. They're not exactly the same because we also said blood has to go from higher pressure to lower pressure. So the ventricular pressure tracing, the blue curve, is a smidge higher than the aortic pressure tracing curve here for the most part, but they run pretty close together compared to the rest of the time where they're nowhere near each other. So then if you forget everything, you can just say, all right, well, I know that the only way blood's going to go from one place to the other is if one pressure tracing is a little higher than the other, and if they're running close together under normal circumstances. And so then therefore, if we have the aortic pressure tracing here and the ventricle pressure tracing up here, then we're talking about blood going from the left ventricle into the aorta. So then we know that has to be the ejection period. By default, that's the only thing that can be happening there. And so then we also know that the other job of the cardiovascular system is to get blood to go from the left atrium into the left ventricle. So then when do we have another time on here where the train tracks run close together? Well, it would be down here at this low pressure, and also here and here, which is just the beginning and the end of the same segment. And so then now we have the left ventricular pressure curve running at a very low pressure, and it's just below the left atrial pressure curve. So then that tells us then that's when blood is going to go from left atrium to left ventricle. So then you could have identified where ventricular filling is happening. And you can see this is divided up into 3 different sections. And so you have to maybe know a little bit more about the different phases of ventricular filling. And we'll talk more about that when we talk about the things that we actually do measure. But you can also sort of figure that out because you have your little A wave here, and you would have your EKG showing also if you were asked to identify these things. And so you know that your P wave would be down here right before your A wave. So that's going to be the atrial contraction part or the atrial kick part of ventricular filling. And then it sort of just makes sense that this first part is going to be when the mitral valve first opens and the ventricle is sort of, the blood is sort of gushing into the ventricle. So that's going to be early rapid filling. And then in between you have a little bit of a lull in the filling, and it slows down a little bit, and then you have diastasis. And so it maybe takes a little bit more thinking to figure out which part of ventricular filling is happening throughout there, but it's easy to figure out when blood is going from the left atrium into the left ventricle. So then we've labeled pretty much all of the Wiggers diagram except for these 2 little spots. And so you'll probably have to know those names too. And so if we look at those 2 little spots and we look at the different pressure tracings and the way that the train tracks would be in relation to each other, the 3 tracks are nowhere near each other except for at the very beginning and at the very end. And we know that we want in general for blood to go from left atrium to left ventricle and from left ventricle to aorta. And that can't possibly happen here because left atrium is lower than left ventricle the whole time, and left ventricle is lower than aorta the whole time. And same with this one, left atrium is lower than left ventricle, which is lower than aorta. So the 3 pressures are nowhere near each other, and the pressure differences, the place where you want blood to go from and to would defy the laws of things that can happen. So then we know that during those times, no blood can be going from the left atrium to the left ventricle, and no blood can be going from the left atrium from the left ventricle to the aorta, because it doesn't work according to those 2 rules that we thought about. So then if no blood is entering the left ventricle and no blood is leaving the left ventricle, then that's going to be your 2 isovolumic periods. And then figuring out, you've heard those words before, I'm sure. So you have isovolumic contraction and isovolumic relaxation. So then figuring out which one is contraction and which one is relaxation is relatively easy because you see the ventricular pressure going up and up and up here. So that's going to be contraction. And then the ventricular pressure going down and down and down there. So that's going to be relaxation. So now you've labeled all the different sections. And so you can memorize those, but if you forget, then you can figure it out. And the only other thing that I didn't block out on here is when the aortic valve opens, closes, and when the mitral valve opens and closes. But you can also figure that out based on what you know is happening. Because if you know that blood is going from left ventricle into the aorta here, then of course the aortic valve has to be open during that period. And if you know that blood is going from left atrium to left ventricle here, then of course the mitral valve has to be open on that period. Or you could think about it that you know no blood is going anywhere during these two sections of isovolumic contraction and relaxation. So both valves have to be closed during that time. So then that would mean one valve has to close at the beginning and another one opens at the end. And then again, one valve has to close at the beginning and the other one opens at the end. So you can figure out what's happening based on with the valves based on when you know blood is going from one place to the next. So then the last thing on the Wiggers diagram that we don't often talk about, but it ends up being kind of important with relation to the other diagrams and also with relation to the way we think about things clinically, is this thing called the LV end diastolic pressure, or the LV-EDP. And so we often try to think about what that pressure would be and measure that and try to quantify that sometimes on echo. And so you can find that pressure on the Wiggers diagram or on a pressure tracing if you recorded it. And it's going to be, it sort of makes sense right here before isovolumic contraction starts, because that's going to be the end of diastole. And it happens to line up with the point of the R wave. So if you have a pressure tracing with an EKG, you would find the point of the R wave and figure out where LV end diastolic pressure is. And it's going to be where the left ventricular pressure and the left atrial pressure diverge, because the left ventricle has started contracting. And so we'll think about that more as we talk about the other diagrams and also as we talk about things from a clinical standpoint. So any questions about the Wiggers diagram before we keep going? Okay. So then the Frank-Starling curve is the next one we'll talk about. And so my sort of just verbal description of this is that it's a curve that demonstrates the relationship between stroke volume and ventricular filling pressures. I think it's easier to look at it, but if you like words better, then that's how I would describe it. It's really a family of curves because you can move, the curve can move around. It's not just one curve. And just good to remember that stroke volume is a determinant of cardiac output. So you have stroke volume times heart rate equals cardiac output. And so then stroke volume and cardiac output are directly related. So that's sort of another way of conceptualizing it. If stroke volume doesn't mean as much to you, then cardiac output probably does. And then the ventricular filling pressure is basically the LV end diastolic pressure that we just talked about. So the amount of pressure that the LV is experiencing right before it starts contracting. And in many circumstances, not 100% of the time, but most of the time, that's going to be approximately similar to the left atrial pressure. And that's going to be approximately similar to the pulmonary capillary wedge pressure. And we'll talk more about the pulmonary capillary wedge pressure in a little bit. So here would be the actual picture, which I think is maybe easier to wrap your head around. So it's basically just a graph, and we have on the y-axis stroke volume and on the x-axis ventricular filling pressure. And here's the Frank-Starling curve, which it doesn't really look all that exciting, just kind of a little swoop. But it's kind of an important thing because you can see that for the vast majority of the curve until you get up here, there's a direct relation, a positive relationship between ventricular filling pressure and stroke volume, meaning that if you fill the ventricle a little bit more with a little bit more pressure, you get an increased stroke volume almost all the time. Eventually, it's going to plateau out and start to fall off if you get really high ventricular filling pressures. But for the most part, if you fill the heart up more, it's going to have a bigger stroke volume to squeeze that blood all out, which kind of makes sense. That sort of is compatible with life. But it helps to know that the heart is able to change those things. And it can't just change things by moving up and down on the curve. You can actually move your curve. And so now we have the dotted line here is your original one. And then we have an exercising dog and the curve moves up and to the left. So now for any given ventricular filling pressure, if we had a line here at some specific ventricular filling pressure, the original stroke volume would be here, and now your stroke volume is up here. So you have a higher stroke volume for any given ventricular filling pressure than you would have had before, which means that when you're exercising, you have improved stroke volume and improved cardiac output without having the pressures inside your heart get higher and higher. So that's a good thing. But the reverse thing can happen if you have a failing heart. So now we still have our dotted curve in the middle, which is the normal. And if your heart starts to fail, then the curve shifts down and to the right. And so now for any given ventricular filling pressure, we have a lower stroke volume than we would normally have had before. And so that's not a good thing, which it means that to maintain the same stroke volume that you had before, you would have to have a higher ventricular filling pressure. And the curve also starts to flatten out. So you have much less area on the curve where a higher ventricular filling pressure actually improves the stroke volume. It plateaus out and starts to fall off sooner. And so your heart is much less responsive to having the ventricular filling pressure increased, to therefore increase stroke volume when it's failing. So then last of all, we'll talk about the Forrester classification scheme, or the wet-dry diagram. And this was designed for people with heart failure. And it's a way of classifying clinical status based on their hemodynamics. But you could it's designed for people with heart failure, but you could put any creature somewhere on this diagram. And so it's kind of a neat diagram because it sort of encompasses everything. And so it's basically a quadrant where any creature at any given time would live in one of these quadrants. And so on the y-axis, we have cardiac output or perfusion. You could think of it either way. And you can see that the top two boxes are red and the bottom two boxes are blue. And so that implies that the top two boxes, you're warm, meaning you have normal cardiac output. So if you're anywhere above this line, your cardiac output is normal. And if you're anywhere below this line, you're cold, meaning you have reduced cardiac output. So that's part of the differentiation. You're either warm with normal cardiac output or you're cold with reduced cardiac output. And then on the x-axis, you have the pulmonary capillary wedge pressure, which we said is often equal to left atrial pressure, LV and diastolic pressure, and a very similar thing to cardiac filling pressures. Another thing that people think about is preload. Sometimes people don't talk about that clinically so much, but conceptually, this would be the same general idea. And we have the right-hand side of this line in the middle with the little water droplets, and the left-hand side with no water droplets. So if you're on the left-hand side of this line, you're dry. And if you're on the right-hand side of this line, you're wet, meaning you have congestive heart failure. So all of us pretty much spend most of our lives living here in the warm and dry quadrant. Even if we get really dehydrated and we sort of work our way down closer to having reduced cardiac output, we're still probably somewhere in this quadrant. And even if we drink a whole bunch or we got a whole bunch of IV fluids, we're still going to probably be somewhere in this quadrant. It would take a lot to get us into one of these other quadrants. And most of our patients are probably living in this quadrant also. But sometimes something goes wrong with the heart and you develop congestive heart failure. And probably the majority of our animals with congestive heart failure are in the warm wet category, meaning they're dyspneic, but they're still bright and alert. So this is the dog that comes in coughing or short of breath, but then you put it in the oxygen cage and it's like digging, trying to get out. It still has perfectly normal cardiac output, but it does have congestive heart failure. So it's warm and wet. And then sometimes we have much sicker looking animals that come in the cold and wet category. And so these animals we are inherently more worried about. They are dyspneic, but they're also flat, they're hypothermic, their paws are cold, their noses are cold, they have poor femoral pulses, and their mucous membrane color is poor. And so in people, it's obvious that if you're cold and wet, you don't do as well as if you're in any of the other categories. And I think we instinctively know that when we see these patients. They're not keeping it a secret. They're really sick, the animals that are in the cold, wet category. And so you need to be very aggressive treating these patients to get them up into the warm and dry category. Whereas if you're warm and wet, you only have to change one thing. You just have to get them to be dry again. Whereas if you're cold and wet, you both have to get them to be dry and you have to improve their cardiac output. So it's harder work to get them normal again. And then sometimes you might have an animal that's cold and dry. A heart failure patient wouldn't usually show up like that in the first place, but we might make a patient cold and dry by giving them a whole bunch of diuretics. Or an animal might fit into this category without having heart disease, like if they have hypovolemic shock or something like that. And so you maybe have noticed that the X and the Y axes on these two graphs, the Forrester classification scheme and the Frank-Starling curve, are very similar. And so we said stroke volume times heart rate equals cardiac output. So stroke volume and cardiac output are sort of representing the same thing. So the y-axis is basically the same. And we said ventricular filling pressure, LV and diastolic pressure is often very similar to left atrial pressure and pulmonary capillary wedge pressure. So the x-axis is also representing basically the same thing. So that means you could take these two curves and pretty much put them with each other and have pulmonary capillary wedge pressure on the x-axis and cardiac output or perfusion on the y-axis, and have your 4 quadrants and put your curves right on top of them. So the dotted line here is the normal one. And so you can see that if you're normal, you spend most of your life on your curve here, and you really have to get to the tail ends of the curve to have something really bad happening and get yourself into another quadrant. But if you have heart failure, you might be on this middle curve, and now your window of feeling good is much, much smaller, and it takes a lot less to push you into being warm and wet or to end up down here cold and dry. And if you have really, really bad heart disease, you might end up on this bottom curve down here where you're never warm and dry at any point on that curve. So the only way to make this animal feel better is to actually improve their cardiac function. So this animal, if it comes in coughing and short of breath, but bright and alert, you could, in theory, just give it some furosemide and dry it out, and you could maybe hit this window. It's still a small window, but you could maybe do that. Whereas if this animal cold and wet came in and you just gave it furosemide, you're going to maybe dry it out, but it's going to end up cold and dry, and it's not going to feel that much better. And so you actually have to do something to improve heart function to move this curve up to here, or to move this curve up to somewhere up here so that you have a better window in the warm and dry section. And so that means we're going to have to do things like give pimobendan or give positive inotropes to actually improve heart function to move the curve up and to the left. So that is the review part of the diagrams. And now we'll talk about some clinical scenarios. Any questions about any of the diagrams themselves before we keep going? Okay. So now we're going to talk about congestive heart failure first, and then pulmonary hypertension. And for each of them, we'll sort of try to tie in the conceptual relevance of the diagrams, and then talk about the things that we actually could measure. We don't usually, but we still think about it a lot, even if we don't measure them a lot. And then we'll talk about the things that we really do measure that you see us do all the time, but we don't always tie it into these graphs or these things that we could measure but don't. So for heart failure, a lot of you see animals with cough or shortness of breath, or sometimes animals that are on fluids that start to get some effusion or tachypnea, and you wonder, is heart failure present? And so you're asking yourselves that question, or you're asking us that question. And to me, that question has 2 components. You're saying, is there fluid where it should not be? So if they're short of breath, you're looking to see, is there pleural effusion or is there pulmonary edema? And then the second part of the question is the heart to blame? So we want to know, we found fluid where it shouldn't be. Is it the heart's fault? And then we can say that heart failure is present. And when we ask the question, is the heart to blame? Like we always say, is it the heart? What we're really saying is the LV end diastolic pressure elevated, which is about the same thing as saying, is the left atrial pressure elevated, which is about the same thing as saying, is the pulmonary capillary wedge pressure elevated? And so those things are all approximately equal in most circumstances. Not always, just a reminder, it's not common, but if you have an obstruction in between the left atrium and the left ventricle, then your LV is sort of isolated from the left atrial pressure and the pulmonary capillary wedge pressure. So the LV won't equal the left atrial and pulmonary capillary wedge pressure anymore. Or if you have an obstruction between the pulmonary capillaries and the left atrium, then your pulmonary capillaries are sort of separated from the left atrium and LV and diastolic pressure, and the pulmonary capillaries won't equal those two. But those 2 things are uncommon. So in general, we think of LV and diastolic pressure, left atrial pressure, pulmonary capillary wedge pressure as sort of interchangeable terms. And when we want to know if heart failure is present, we want to know if those things are elevated. And so when we go back to our diagrams, that sort of directly ties into what we talked about with both the Forrester classification and the Frank-Starling curves, where we said, this is the cutoff. This line is the cutoff between being dry and being wet, between not having congestive heart failure and having congestive heart failure. And so you could pick a number, which isn't maybe going to be exactly the same for every animal, but we'll say maybe around 18 millimeters of mercury for a dog or 15 millimeters of mercury for a cat. And so if you have a higher pressure, a higher pulmonary capillary wedge pressure than that, then you probably are short of breath from heart failure. And so that makes it helpful, because if you could just know what the pulmonary capillary wedge pressure is, that gives you a huge amount of information. And how does that tie into the actual Wiggers diagram? So we don't always think about the Wiggers diagram in terms of how it would change in pathologic situations, but because it's just pressure tracings, you can sort of think about it that way. So if we give ourselves some numbers here and we have our left ventricular pressure tracing that goes up to 120 in systole, the LV end diastolic pressure normally is maybe around 8 millimeters of mercury. And so then if something goes wrong in the heart, then that means that the heart's normal efficiency is going to be disrupted. And when you disrupt the heart's normal efficiency, then it's going to take more pressure to fill the heart than it used to. So now we're going to have an LV end diastolic pressure that's elevated, that's somewhere up here. Maybe it's up around 18 millimeters of mercury. And so we know from what we said about the Wiggers diagram that if the LV pressure is up here around 18 millimeters of mercury, there is no possible way now to get blood from the left atrium into the left ventricle. So if we want to stay alive, the left atrial pressure has to move from where it was normally down here to somewhere up here. And the actual shape of the waveforms may change a little bit also, but the general principle is that if the LV end diastolic pressure has increased, the filling pressures are increased, the left atrial pressure has to also be increased in order to ever get blood going from left atrium into the left ventricle. So then we could actually measure any of those things. We could go and measure the left atrial pressure, the LV end diastolic pressure, or the pulmonary capillary wedge pressure. So I'm just going to tell you a little bit about how one could measure those, even though we don't usually do it, but maybe that helps conceptualize how one would go about this if you wanted to. And so if you wanted to measure the left atrial pressure, you'd be trying to get a pressure tracing like the yellow line on our Wiggers diagram with an A wave, a C wave, and a V wave. And so you could put a catheter into the actual left atrium. And so this is showing an angiogram, which you wouldn't have to do the angiogram part of it to measure pressure, but it helps you see things. So this dog's head's down here and the catheter is coming from the jugular vein into the cranial cava, through the right atrium, across the interatrial septum, into the left atrium. And then there's contrast going into the left atrium, left ventricle, and then out into the aorta. And so you could take this catheter and hook it up to a pressure system and measure the pressure in the left atrium. And then you would know if it's high or if it's normal. But to get there, I said you had to go from the right atrium across the interatrial septum, which usually would entail poking a hole in the interatrial septum, which you don't really want to do just for the sake of measuring pressure. That's kind of a little bit of an invasive thing to do. This dog had a giant atrial septal defect, so the catheter went right across it. But in general, you're not going to have that luxury. You're not going to be able to just shove a catheter into the left atrium easily. And so because the left atrium is hard to get to from a catheter, especially from a vein and even from an artery, we don't really like to go backwards across the aorta and then backwards across the mitral valve to get to the left atrium. We're not really going to measure the left atrial pressure directly very often because that's just kind of an invasive thing to do, but you could. So what about the LV end diastolic pressure? So we could take a catheter either from the femoral artery, like in this dog, and come down the aorta, around the aortic arch, across the aortic valve into the left ventricle, or you could cut down to the carotid artery and put it down into the aorta and into the left ventricle. And you could get a pressure tracing that looks just like the ventricular part of the Wiggers diagram. And you could say, what's my LV end diastolic pressure, which is going to be right at the point of the R wave, and you could measure it, and then you would know what the LV end diastolic pressure is. But it's a little bit invasive to cut down to an artery. We don't do that regularly just to know what the LV end diastolic pressure is. We also don't like to shove things backwards across the aortic valve just willy-nilly. And so you wouldn't necessarily go shoving a catheter down in the left ventricle just for the sake of knowing what the LV end diastolic pressure is, but you could do it. And that's how you would get a pressure tracing that looks like the ventricular part of the Wiggers diagram. So what about the pulmonary capillary wedge pressure? This one is the most realistic of the three to do. So now we again have a catheter coming from the jugular vein, which you can do percutaneously and just put a sort of an introducer type thing in the neck, and you don't even have to cut down necessarily, and then put a catheter down into the cranial cava, through the right atrium, right ventricle, right ventricular outflow tract, across the pulmonic valve, and then out into the main pulmonary artery. And then if you look closely, there's a little balloon blown up on the end here. And so to get the pulmonary capillary wedge pressure, you would have the catheter in the main pulmonary artery, and then you would blow up the balloon, and the balloon would float as far out as it can into a pulmonary artery branch and wedge itself out there. And then when you measure pressure, you're measuring pressure from just beyond the balloon. And so that gives you the actual pressure in the pulmonary capillaries. And we call it the pulmonary capillary wedge pressure because the balloon has wedged itself out in there, and then it's looking beyond it to measure the pulmonary capillary pressure. And so this is something that's done relatively frequently in people with bad heart disease or people that are very sick in ICUs to try to sort out, is their pulmonary capillary wedge pressure normal or not? And in people, they might do it even just bedside without fluoro. We don't do this very often in animals just for the sake of measuring the pulmonary capillary wedge pressure, because most of us would feel more comfortable doing it with fluoro, with the animal under anesthesia, not moving around, and you still need to put a big introducer in the neck. And most of our animals where we really want to know, is the pulmonary capillary wedge pressure high or not, are kind of short of breath. And so it's not always an easy thing to do, but we would really love to do it in many cases. The animals that are hard to sort out, we would really love to say, like, what is your actual pulmonary capillary wedge pressure? And we could technically measure it without being too invasive, but we often don't do it, partly because of them being short of breath and partly because some animals are a little too small to make it comfortable. But it would be a very realistic thing to do, and they do it relatively frequently in people. So what do we actually try to measure on these animals to sort out if the animal has heart failure, i.e. does it have a high LV end diastolic pressure, pulmonary capillary wedge pressure, left atrial pressure, et cetera? And so mostly we do echo. And the first thing we do on echo is just look at the 2D appearance. And so and that we obsess over the size of the left atrium, and so do you guys. And that's because the bigger something is, the more pressure is going to be in there. Volume and pressure are related. And so when we look at this animal with a very big left atrium, we presume that the pressure inside the left atrium is elevated. So that's the sort of a rudimentary thing, but it's simple, and we do it a lot, and you do it a lot, because we're trying to sort out, is there high left atrial pressure? And the bigger the left atrium is, the more you believe that the pressure in there is high. There are times where the left atrium hasn't had time to get big and it's not as big as you want it to be, but the pressure is still very high. And so just knowing whether or not it's big doesn't always give you the end answer, but it's helpful because the bigger it is, the more you believe that the pressure in there is probably high. The other thing that we do on echo that you see us do all the time is diastolic function assessment. And so that means that, again, we said what we care about is the LV end diastolic pressure. So we're wondering about something to do with the ventricle during diastole. And so that means that we're going to be looking at this part of the curve where we said ventricular filling is happening. And so we're watching blood go from the left atrium to the left ventricle and measuring how it gets there and what the velocity of blood flow is during different phases of ventricular filling. And this is when maybe it might help to have another part of the Wiggers diagram on here, which is the ventricular volume part. So I didn't talk about that a lot before, but it's fairly self-explanatory. You can sort of just follow the volume along and see what happens. And so you have isovolumic contraction here where the volume doesn't really change. And then when ejection is happening, the ventricular volume is going down, 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 and then it doesn't change during isovolumic relaxation. And then we said when the mitral valve first opens, the blood gushes into the ventricle, and then that would mean that your ventricular volume really rapidly goes up. So that's early rapid filling. And then it sort of plateaus off, fills a little bit slower during diastasis. And then there's this extra little bump here with atrial contraction at the end. And so we actually can see different things happening on echo during those different phases. And you've seen us do this lots and lots of times when we get the heart from the left side of the chest. So we have the left ventricle up here and the left atrium here and the mitral valve in the middle. And then we're watching the velocity of blood flow go across the mitral valve from left atrium to left ventricle. And we get the E wave with the early rapid filling and then the A wave with the atrial kick. And normally the E wave is a little bigger than the A wave. And that sort of makes sense with what we saw on the Wiggers diagram. But that can change when things happen to the heart. And so I'm not going to dwell on this too much because you don't have to think too much about actual echo numbers and things like that. But it turns out you can get a lot of information from this E and A wave. And we also will put the cursor right on the edge of the heart and measure the velocity of the myocardial movement at the same times. And then we get the E prime and the A prime waves, and we call that tissue Doppler. And so normally you have your E and your A with your E being bigger than your A, and your E prime and your A prime with your E prime being bigger than your A prime. And you can have situations where the heart has impaired function, but the left atrial pressure is not high, which would be this one. And so that would be called delayed relaxation. So the heart's having trouble relaxing. The early filling is not as robust because the heart's not relaxing as well as it should be. And you're relying more on a contribution from atrial kick at the end. So your E and your A wave become inverted, and your E prime and your A prime become inverted. But When that happens, that means your heart's efficiency is disrupted, and over time, you're going to get elevated left atrial pressure. So that once you get a high left atrial pressure, then that high left atrial pressure is going to like push this gush of blood in more rapidly with the early filling, and you're going to get a more feeble contribution from your A wave. So then you get an E wave that's much bigger than the A wave, and your E prime and your A prime stay pretty small. And so someone sorted out that if you take the ratio of E to E prime, the actual number that you get if the velocity of the E wave is divided by the velocity of the E prime wave, then you get a number that approximates pulmonary capillary wedge pressure. So you'll see us look at the measurements at the end and actually look at the E to E prime to see what the actual number is, because that gives you a ballpark idea. People have actually measured them and measured the pulmonary capillary wedge pressure directly, and the two seem to run very similar. And so when an animal is in heart failure, we're expecting the pulmonary capillary wedge pressure to be high. And so then we use the E to E prime as a number that might give us an idea of what the pulmonary capillary wedge pressure is. And we use the actual height of the E wave as a number that might give us an idea that there's elevated left atrial pressure. So that's it for the heart failure part. Now we'll talk about pulmonary hypertension a little bit. And so I think you all probably have to be pretty familiar with pulmonary hypertension. There are different groups of pulmonary hypertension, which I'm sure you all know. There's either 5 groups if you go with the human classification scheme, or 6 groups if you go with the veterinary consensus statement. The first 4 groups are the same for both of them. So pulmonary arterial hypertension, left-sided heart disease, primary pulmonary disease, thromboembolic disease, and then 5 is miscellaneous for people, or 5 is parasitic for veterinary, and then 6 is miscellaneous for veterinary. I wish they were the same, but they're almost the same. And then the other way that people group pulmonary hypertension is to say that it's either post-capillary or it's pre-capillary. And that basically means it's left heart disease, i.e. it's number 2, or it's something else, any of the other ones. So it's either post-capillary left heart disease, pulmonary hypertension, group 2, or pulmonary hypertension from any other cause, which is pre-capillary. And so how does that tie into our diagrams? Well, the first simple way is that if you're trying to figure out if it's post-capillary versus pre-capillary, what you're asking is the pulmonary capillary wedge pressure elevated or not? So if you have pulmonary hypertension and the pulmonary capillary wedge pressure is elevated, higher than 18 for a dog or 15 for a cat, then you would say it's post-capillary pulmonary hypertension. It's pulmonary hypertension from left heart disease. Whereas if you have pulmonary hypertension, but the capillary wedge pressure is normal, then you'd be thinking it's pre-capillary pulmonary hypertension from some other cause besides left-sided heart disease. The other thing that I think maybe conceptually helps understand what happens with pulmonary hypertension, especially when it comes to the things that we measure on echo, is what happens to the actual pressure tracings. And so we don't think of the Wiggers diagram with the right heart very often, but you can get the same general pressure tracings. And so we have the right ventricular pressure here, and then the pulmonary artery pressure here. And now our systolic pressure is around 25 instead of 120 for the left ventricle. But the general shape of the curves is pretty similar. So if something happens, whatever the cause is, that makes your pulmonary arterial pressure go way up high, so now maybe the systolic pulmonary pressure is 60 or something like that, or even higher. Now you have pulmonary hypertension, doesn't matter what caused it. And we know, again, from the rules that we said about the Wiggers diagram, that you can't keep your RV pressure down here at 25 if your PA pressure is 60, because that means you'll never get blood from the right ventricle into the PA. That's impossible. So if the PA pressure has gone up to 60, then the RV pressure also has to go up into that ballpark, even a smidge higher, to get blood to go from right ventricle into pulmonary artery during systole. And so we don't necessarily do that stuff, those sort of mental acrobatics with the Wiggers diagram itself, but that's what would be happening with the pressures. And that becomes important when we talk about the things that we actually do measure. So first off, the things that we could measure, we could just go and measure all of those things directly, the right ventricular pressure, the PA pressure, and the pulmonary capillary wedge pressure. Those would all be relatively easy things to measure without being, you don't have to cut down to an artery, you can do it all from the jugular vein. We don't do it a lot, but we could. So we could take a catheter from the jugular vein through the cranial cava, through the right atrium into the right ventricle, and hook it up to a pressure tracing and get our RV pressure. And that would look just like the RV portion of, or the LV portion of the Wiggers diagram, except for lower pressures. And so we do that all the time when we do cath procedures for dogs with pulmonic stenosis. We would not do it all the time trying to sort out if pulmonary hypertension is present, because it still is a little bit invasive, but you could do it. And you could keep on pushing your catheter out past the pulmonic valve into the main pulmonary artery, and you could just directly measure the PA pressure. And that would tell you, is pulmonary hypertension present or not? Because it would tell you exactly what the pulmonary artery pressure is. And we talked before about the pulmonary capillary wedge pressure, which would mean you would take your catheter just like this, that does not have a balloon blown up. And so that's the first picture. And then you would blow up the balloon, and the balloon would suck it out into the distal pulmonary artery branch. And so you can see that the catheter has moved from being like just below the trachea and pulled out as far as it could go with the balloon. And that measures the pulmonary capillary wedge pressure. And then you could say, is there pulmonary hypertension, and is it pre-capillary or post-capillary? And so we don't do that a lot, because a lot of these animals where we wonder if they have pulmonary hypertension are pretty short of breath. We don't really want to sedate them or anesthetize them. We don't really want to put a big catheter in their jugular vein, but we could do it. And that would be very helpful in some cases where we're not sure what's happening. So what do we actually do? Again, we're going to come back to echo. And just like with the left with heart failure, we're going to look a lot at the actual 2D appearance of things. So you're all probably used to seeing the classic pulmonary hypertension echo with the little tiny left ventricle that's not really getting enough blood back to it, dilated right ventricle with RV hypertrophy, sometimes even more impressive RV hypertrophy than this dog had, and then the big dilated pulmonary artery that's bigger than the aorta. All of those things would be very suggestive that pulmonary hypertension is present because of the secondary structural changes that the pulmonary hypertension has created inside the heart. But we really like numbers. And so we really like measuring pressure gradients when it comes to pulmonary hypertension, specifically the tricuspid regurgitation and the pulmonic insufficiency, because those are going to give us a lot of information about what the pulmonary arterial pressures might be. So first, tricuspid regurgitation. So you guys see us do this all the time. If we have a nice big jet of tricuspid regurgitation like this dog, so we have right ventricle down here, left right atrium up here, tricuspid valve, and a nice good jet of tricuspid regurgitation, then we can get this really pretty envelope picture, and we measure the velocity of blood flow as it regurgitates between right ventricle and right atrium. You've seen us when you've asked for consults wondering if there's pulmonary hypertension on those dogs that don't have a lot of tricuspid regurgitation. And then this is very hard to measure, because if they don't have tricuspid regurgitation, you can't get these pretty pictures. So then we'll struggle and try to get some less pretty pictures, or sometimes you can't get it at all. But when you have tricuspid regurgitation, it's very helpful. And so we get ultimately the speed of blood as it regurgitates between right ventricle and right atrium. But what we've been talking about this whole time is pressure. So obviously we have to take our little Bernoulli here and do the 4V squared with the modified Bernoulli to get the actual pressure difference between the right ventricle and the right atrium. And so why does it help us? We said we wanted to know pulmonary artery pressure. Why does it help us to know the pressure difference between the right ventricle and the right atrium? Well, that comes back to the actual way that the Wiggers diagram looks and works. And so we said that this is the speed of blood between the right ventricle and right atrium. We'll say it's around 5 meters per second. So 4V squared would give us 100. So that's saying that there's 100 millimeter of mercury difference between the pressure in systole in the right ventricle and the pressure in systole in the right atrium. And so we said before that normally blood should not go from one curve in the Wiggers diagram to a place that's so far away. But if you poke a hole somewhere that there shouldn't be a hole, blood will still go from high pressure to low pressure. And so the pressure in the ventricle is much higher than the pressure in the atrium. So you will have blood going from one curve that's to a very distant curve if one curve is much, if it's able to go from high pressure to low pressure. So if we know that the pressure difference between the right ventricle and the right atrium is around 100, then we remember that our arterial pressure tracing runs just about close to being exactly the same as the right ventricular systolic pressure. Then that would tell us that the PA systolic pressure is around 100. Technically, you'd have to add this little bit of right atrial pressure to it to get the number, but that's usually a relatively small number. And so then we get a ballpark PA pressure of around 100, which we know is much too high, as long as everything else is normal in the heart. If you had pulmonic stenosis, that would throw off this relationship. So we have to know that we don't have pulmonic stenosis, but as long as you don't have that, then these two run close together. So figuring out what this difference is gives you an idea of what the PA pressure is. So then what about pulmonic insufficiency? Sometimes we don't have a lot of tricuspid regurgitation, but we do have some pulmonic insufficiency, or sometimes we have both and we'll try to measure both. And so pulmonic insufficiency is going to happen in diastole. And so then the 2 times that pulmonic insufficiency is going to get measured is early diastole, right after the pulmonic valve is supposed to have closed, and then end diastole right before ventricular contraction starts. And these aren't the prettiest tracings, but you can especially see on this one, there's a little bit of a slant there. And so we would be measuring the pressure here at early diastole, right when the waveform starts, and then here at end diastole. And these things give us an approximation of the mean PA pressure at the top and the end diastolic PA pressure at the bottom. And so the first measurement would be giving you the pressure difference between the pulmonary artery and the right ventricle during this phase right here. And then the second measurement would be giving you the pressure difference between the pulmonary artery and the right ventricle at this phase here, right before ventricular contraction. And so that's going to give you a ballpark idea of around what the mean PA pressure would be and around what the end diastolic PA pressure would be. So we also use those to sort out if there's pulmonary hypertension, especially if we don't have tricuspid regurgitation to rely on, or just to give us another data point to say that we think the PA pressures are high. So that brings me to the end. I think to me, the conclusions are that we think about these things a lot, maybe more than you realize, and we don't always talk about the way that we're making those connections, but the diagrams do sort of pertain to the things that we think about on the regular basis. So from Otto's perspective, I think it's very clear that Wiggers, Frank, Starling, and Forrester are super cool, and we should not forget about Bernoulli. Bernoulli is necessary for all of this too. And so I think that a lot of information can be gained from those diagrams, and you don't necessarily have to memorize anything because they kind of just make sense if you can sort of piece them apart, and we think about them all the time. So I'm happy to try to answer any questions, or otherwise we can be done. John said he was going to troll me in the chat, but he did not do that. All right. Thanks, guys. I think if you don't have any questions, then we are all set. I hope you guys have a good day.